We will switch gears now, and we will welcome Dr. Stuart Schnitt, breast pathologist, who will talk to us about the high-risk lesions, the changes in the breast tissue that can elevate a woman's breast cancer risk. So welcome, Dr. Schnitt.
Okay, so as Dr. King said, I'll be talking about high-risk breast lesions, and I'd like to thank Dr. King for inviting me to participate. So what are high-risk lesions? So breast lesions that are defined as high-risk breast lesions are those that are associated with an increased risk for the subsequent development of breast cancer based on the results of long-term follow-up studies. And in fact, this has been the definition of high-risk lesions for several decades. But in addition, in current practice, the term high-risk lesion is also used to refer to lesions at high risk for upgrade to a worse lesion at surgical excision following a diagnosis in a core needle biopsy. So basically what we're talking about here are the long-term concern for the future risk of breast cancer and the short-term concern for a potential for the presence of a concurrent worse lesion missed by core needle biopsy and requiring treatment at the time of the biopsy. And by a worse lesion, we mean DCIS or invasive cancer. So what are high-risk lesions in the breast? Well, there are basically four, and you've heard a little bit about these already. ADH or atypical ductal hyperplasia, ALH or atypical lobular hyperplasia, LCIS or lobular carcinoma in situ, and DCIS or ductal carcinoma in situ. So let's first focus on the long-term concern, that is the future risk of breast cancer associated with these various high-risk lesions. And this table summarizes a lot of data from a whole bunch of studies over a long period of time, looking at the relative risk and location of subsequent breast cancers in women with high-risk lesions. So you can see for atypical ductal hyperplasia or ADH, the relative risk is 3 to 5-fold. And the cancers that develop can occur in either breast. There's a predominance in the ipsilateral breast, that is the side which had the biopsy in some studies, but with long-term follow-up, the risk is about equal in either breast. And similarly, for atypical lobular hyperplasia, the risk is slightly higher, 4 to 6-fold, and these subsequent cancers can occur in either breast. Similarly, for lobular carcinoma in situ, there's a slightly higher increase in the relative risk, 8 to 10-fold. And again, these cancers that develop in women with LCIS, ALH, and ADH can occur in either breast. And that's why these are considered high-risk lesions rather than direct precursors to invasive breast cancer in terms of conceptualizing how they're managed clinically. DCIS is a bit different. That has about an 8 to 10-fold increase in risk, but the subsequent breast cancers are almost always in the same breast at the same site as the original ductal carcinoma in situ. And we talked about DCIS at length in the spring BPREP forum, so I'm not going to talk about that any further. We'll focus on these other high-risk lesions, ADH, ALH, and LCIS, starting with the atypical hyperplasias. So the risk associated with these lesions was really first brought to our attention in this seminal study published by DuPont and Page in the New England Journal of Medicine almost 40 years ago. And they basically looked at women who had benign breast biopsies, looked at the findings in the benign breast biopsies, and related these findings to the subsequent risk of development of breast cancer. And the benign breast biopsies were subdivided into 3 categories: non-proliferative lesions, proliferative lesions without atypia, and the atypical hyperplasias, ADH and ALH. And what they found in this study was that proliferative lesions without atypia, the most common being what we call usual ductal hyperplasia, is associated with a relative risk of 1.9, or about 2 times the risk seen in the reference population. In contrast, the relative risk associated with the atypical hyperplasias was much higher, about 5-fold compared to the reference population. And subsequent to the DuPont and Page study from Nashville, which are the bars in gray, There have been four large clinical follow-up studies of benign breast disease and breast cancer risk, which in aggregate contain more than 16,000 women. And despite differences in patient populations and differences in pathologists who reviewed the slides, the results of these studies is very consistent. And I think it's now firmly established that proliferative lesions without atypia, like usual ductal hyperplasia, sclerosing adenosis, things like that, are associated with about a 1.5 to 2-fold increased risk, whereas the atypical hyperplasias are associated with a much higher risk, a 4 to 5-fold increase in risk. Now, how common are atypical hyperplasias before everybody panics and starts worrying about this? Atypical hyperplasias are relatively uncommon. In the pre-mammographic era, where breast biopsies were performed because of a palpable mass or something you could feel, only about 4% of breast biopsies showed atypical hyperplasia. Currently, with the use of screening mammography, approximately 10% of breast biopsies or so show atypical hyperplasia. So even though this is more than doubled in detection since the pre-mammographic era, still only 1 in 10 breast biopsies will show atypical hyperplasias. We've also learned over the last 20 years or 30 years or so that there are several factors that can modify the breast cancer risk in women with atypical hyperplasia. So everyone with atypical hyperplasia is not necessarily at the same level of risk. And these include a family history of breast cancer, the time since the biopsy, how long it's been since you've had the biopsy, the type of atypical hyperplasia and the age of the woman who had the biopsy, the extent of the atypical hyperplasia, and the presence of lobular involution. And I'll go through this relatively quickly to give you a sense of how these impact the risk. So first, with regard to family history, the study from DuPont and Page from Nashville indicated that the presence of a family history further increases the risk among women with atypical hyperplasia. In fact, this was one of the major points of their paper published in 1985. But in the Nurses' Health Study and the Mayo Clinic study, there was no significant additive effect of family history to risk associated with atypical hyperplasia. So this is kind of an unresolved issue, although many clinicians, of course, are very concerned when there is a family history concurrent with the presence of atypical hyperplasia. What about the time since biopsy? Well, in the Nashville study, they found that the risk associated with atypical hyperplasias was greatest within the first 10 years and then decreased over time. But again, the Nurses' Health Study and the Mayo Clinic study have found something somewhat different. They found that the risk is fairly constant over time. And these are data from the Mayo Clinic study showing the risk associated with atypical hyperplasia over time for the subsequent development of breast cancer. And you can see that this is a fairly constant line going from the time of the initial biopsy out through 25 years, with a risk, an absolute risk of developing breast cancer of about 1% per year in women with atypical hyperplasias. What about the type of atypical hyperplasia and the age of the woman? So in the Nashville study, they found that the risk was greater for atypical lobular than atypical ductal hyperplasia, but that this risk did not vary with the age or the menopausal status of the women. In contrast, in the Nurses' Health Study, they also found that the risk was greater for atypical lobular than ductal hyperplasia, but this was especially true in younger or premenopausal women. And in the Mayo Clinic study, the risk was similar for atypical lobular and ductal hyperplasia, and this was higher in younger women. So again, there's no real resolution to this issue. Two of the studies suggest that the risk is greater for atypical lobular than ductal hyperplasia. Two of the studies suggest that the risk is higher in younger women. But again, this is not a definitively resolved issue. Now, what about the extent of atypical hyperplasia? Well, these are data from the Mayo Clinic to show that there's basically a dose effect, that the fewer number of foci of atypical hyperplasia, the lower the risk. However, in all of these categories, whether there's 1, 2, or 3 or more foci, the risk is quite high. One of the problems with this study is that it's not stratified by the type of atypical hyperplasia, so it's not clear from these data whether the number of foci apply to ADH, ALH, or both. We did a similar study in the Nurses' Health Study published almost 10 years ago, showing that there was a trend toward a higher risk of breast cancer among women with more foci of atypical hyperplasia, going from about 4 with 1 focus to 4.5 with 2 foci to over 5 with more than 3 foci. However, what we found in this study was that this was primarily related to atypical lobular hyperplasia, not atypical ductal hyperplasia. Now, what about lobular involution? You heard something about that a little earlier. As women age, the lobules, or these little glandular structures in the breast, get smaller and involute. And in a very nice study from the Mayo Clinic, they found that age-related lobular involution had an impact on the risk associated with different forms of benign breast disease. And if you look at the group of bars on the right, where it says AH, you can see that women with atypical hyperplasia and no involution, that's the N, have about an 8-fold increased risk, whereas those with atypical hyperplasia and complete lobular involution, the C on the right, the risk is markedly reduced to that of women with usual ductal hyperplasia. So it does seem like the background breast tissue gives you some indication of the risk associated with atypical hyperplasias. This may be because atrophy signals poor, lower levels of estrogen, which likely drive these atypical hyperplasias. So it's not terribly surprising that women with a lot of atrophy and lower levels of estrogen have less of an estrogen drive on their atypical hyperplasias and are less likely to develop breast cancer than women with less lobular involution. So now that we've talked about the atypical hyperplasias, let's move on to lobular carcinoma in situ, which is associated with about an 8 to 10-fold increased risk. And again, with long-term follow-up, the risk is about equal in both breasts. Now, LCIS is not one disease. The World Health Organization recognizes 3 different variants of LCIS. The most common is the classic type, and that's where most of the data are from regarding LCIS and breast cancer risk. But there are also 2 other types that are less common, the pleomorphic type and the florid type. Now, this is a study that Dr. King published a long time ago, almost 10 years ago, looking at the absolute risk of breast cancer among women with classic LCIS and long-term follow-up from Memorial Sloan Kettering Cancer Center. And you can see that there were over 1,000 women with LCIS with long-term follow-up. And overall, the risk of subsequent DCIS or invasive cancer in these women was about 1 to 2% per year and was fairly constant over 15 years of follow-up. So at 15 years of follow-up, about 17% of women with LCIS developed invasive breast cancer, about 8% or 9% developed DCIS. Now, what about pleomorphic lobular carcinoma in situ? Well, unfortunately, we're essentially in a data-free zone. There are no clinical follow-up studies akin to those available for classic LCIS and DCIS to inform us about the natural history and biologic behavior of these lesions. And really, the natural history and biologic behavior is unknown. There is some data to suggest that these lesions are more often associated with contemporaneous or simultaneous invasive cancer than is classic LCIS, but the risk factors for local recurrence or progression to invasive cancer among patients with pleomorphic LCIS are not established. There are no prospective data, and as a result, the appropriate management is uncertain. So how is pleomorphic LCIS managed in current clinical practice? Well, again, this varies all over the place. There is some evidence to suggest that excision to negative margins decreases the risk of local recurrence or progression to invasive breast cancer among patients with pleomorphic LCIS, but the adequate negative margin distance is unknown. Furthermore, the benefits of chemoprevention or radiation therapy in treating these patients is uncertain. And what Dr. King likes to say is that in the B-PREP clinic and in other areas where patients with these lesions are seen, they take a pragmatic approach to management and do individualized management based on multidisciplinary evaluation and global risk assessment. For florid LCIS, we have the same issues as those discussed for pleomorphic LCIS, but we have even less data. The cells have a lobular phenotype. They look lobular, but they have these big areas of necrosis or dead cells in the middle of the ducts, which is a worrisome feature. But the natural history is unknown, and it's not really clear whether these lesions should be treated more like classic LCIS or like DCIS. So that's a brief summary of the long-term risk associated with these various high-risk lesions. Let's now focus on the short-term concern, which is the potential for the presence of a concurrent worst lesion that was missed by the core needle biopsy in which atypical hyperplasias or these other high-risk lesions were diagnosed and that required treatment at that time. So we'll do these one at a time. Atypical ductal hyperplasia, the reported upgrade rate to something worse after a core needle biopsy for ADH is all over the place in the literature, anywhere from 13% to over 50%. However, we recognize now that some of these older studies didn't correct for other abnormalities like other findings on the mammogram, the number of sections that were taken, et cetera, the mammographic findings. So what we now do is primarily focus on patients with concordant imaging findings in which the findings on the imaging studies correlate with what's seen on the biopsy. So even in these situations, among patients with concordant imaging findings, the upgrade rate for atypical ductal hyperplasia is about 20%. Most of the upgrades are to DCIS. This was a study from the Mayo Clinic where they looked at about 400 patients with ADH diagnosed on core needle biopsy, and they defined a low-risk group among these patients, that is low risk for an upgrade to a worse lesion at the time of the biopsy. And they defined the low-risk lesion as having no individual cell necrosis or no dying cells, and either a single focus of ADH with more than 50% of the mammographic calcifications removed, or 2 to 3 foci of ADH with 90% or more removal of the mammographic abnormality. And what they found in this study is that the upgrade rate to a worse lesion in the low-risk group was about 5% compared to 21% among others. But 5% is still a fairly substantial upgrade rate. In a study that we did several years ago, we looked at almost 300 patients with ADH on a core needle biopsies. 16% of these patients had upgrades at surgical excision, mostly to DCIS. But what we found was that there were several features associated with an upgrade. For example, more involvement of the ducts in the breast was associated with a higher upgrade rate than those with fewer areas of involvement. And those in which the atypia in the biopsy looked really bad and was bordering on DCIS had higher upgrade rates than those in which the ADH didn't look quite as bad. And when we combine these features, what we found was that if there was more involvement, more than 3 or more terminal duct lobular units, and the lesion was bordering on DCIS under the microscope, the upgrade rate was very high, 54%. In contrast, if there was only very limited involvement by ADH and it was not bordering on DCIS, the upgrade rate was about 7%. But again, 7% is felt by most clinicians and radiologists to be too high. So where are we with stratifying patients with ADH and identifying those that may not need a surgical excision at the time of the biopsy? I think we're getting better at identifying a subset of patients with ADH on core needle biopsy who can safely be spared excision. For example, those with a limited extent of the lesion that's not bordering on DCIS and in whom most of the mammographic calcifications have been removed. But I don't think we are quite there yet. So our current clinical practice is surgical excision for all patients with ADH on a core needle biopsy to ensure that they don't have something worse in the breast at that time. Now, what about atypical lobular hyperplasia and lobular carcinoma in situ? Well, many studies combine these two under the heading of lobular neoplasia. So you'll see that term sometimes. So where are we with our understanding of upgrade rates to a worse lesion for LCIS and ALH? Well, again, like for ADH, the literature is all over the place. The upgrade rate for LCIS was reported to be anywhere from 5 to 60%, and for ALH, anywhere from 0 to 67%. But again, we now know that among patients with concordant imaging findings, the upgrade rates are much lower, around 4%. And again, most of these upgrades are to DCIS. In a study done by one of the surgeons in our group, Faina Naklis, through the Translational Breast Cancer Research Consortium, otherwise known as the TBCRC, this was a prospective study of upgrade rates of lobular neoplasia on core biopsy in women with concordant imaging findings. And in that study, the upgrade rate was extremely low. It was only about 1% based on central pathology review. So based on these more recent studies in which there's concordant imaging findings, it's felt by our group that ALH and LCIS can probably safely be managed without surgical excision in most patients. So in this study published by Dr. King's group a couple of years ago, they had 80 patients with lobular neoplasia on core needle biopsy and concordant imaging findings who were managed without surgical excision. And with a median follow-up of a little over 2 years, no patient developed a breast cancer in the same quadrant of the breast in which the biopsy was performed. There was only about a 6% need at 3 years for patients to undergo a surgical excision, and the risk of having a biopsy at the same site over 3 years was only about 9%. So it was concluded from this study that non-surgical management of lobular neoplasia on core needle biopsy is safe, and that there's a low likelihood of requiring a subsequent surgical excision or a repeat core needle biopsy. So again, at our institution, our current practice is that for patients with lobular neoplasia, either ALH or LCIS, on a core needle biopsy and concordant imaging findings, these patients are offered the option of follow-up without surgical excision. Now, for the lobular carcinoma in situ variants that I mentioned before, like pleomorphic and florid LCIS, that's a totally different story. And if you just look at the red boxed line on the bottom, among patients with these lobular variants on core needle biopsy, the upgrade rate to a worse lesion, that is DCIS or invasive cancer, at that time is about 50%. So it's clear that these patients always need an excision if these lesions are diagnosed on core needle biopsy. So do all high-risk lesions detected on core needle biopsy still require excision? Here is a summary and recommendations, and this is from a consensus guideline published by a surgical group several years ago. And what they said was that routine excision of every borderline or high-risk lesion is not recommended, that patients with suspicious clinical or imaging findings discordant with the core needle biopsy pathology should be recommended for excision, but that there should be selective excision for the remaining patients. The estimates of upgrade to malignancy are clearly improved with multidisciplinary input, and that the final decision on whether or not to excise depends on shared decision-making with the patient. So here are their recommendations. For ADH, surgical excision is still recommended, but they say that perhaps small volume ADH, if completely excised in the core needle biopsy, can be observed based on risk factor assessment and multidisciplinary input. In contrast, for LCIS and ALH, they recommend the potential for observation with clinical and imaging follow-up, but say excision is necessary if the pathology is discordant, if there's limited sampling, or if other high-risk lesions like ADH are present. And as I just said, that for pleomorphic LCIS, surgical excision is required. So in conclusion, high-risk lesions are associated with a variably increased risk of subsequent breast cancer based on the results of long-term follow-up studies. The level of risk, as you've seen, may be modified by other factors. High-risk lesions that are identified in core needle biopsy are also associated with a variable upgrade rate to a worse lesion like DCIS or invasive cancer. And the accurate and reproducible identification of patients with high-risk lesions on core needle biopsy who can be spared surgical excision is an important clinical goal. So with that, I will stop and open it up for questions.
Thank you, Dr. Schnitt. So a really wonderful review of the literature. I think as physicians, we often interpret the literature and we say how many women with a lesion will develop breast cancer. And I think for our patients, sometimes it would be nice for them to hear us say how many women with this lesion will not develop breast cancer. So based on that sort of summary of the atypias, what would you say, how many, we know it's about 1% per year. So what would you say as far as how many women can live with their atypia for the rest of their life and probably won't get breast cancer?
Yeah, well, again, I think that this is a bit age dependent. I think that, of course, if a woman is younger and has other risk factors, I think the risk is likely to be higher than an older woman with a small amount of atypia. But most women with atypical hyperplasia do not develop breast cancer, even those that have more foci and not all of the abnormality removed. So I think the take-home message here is, yes, atypical hyperplasias are associated with a high risk, but most women with atypical hyperplasias do not develop breast cancer. In fact, when we first published the Nurses' Health Study in JAMA in 1992, I was interviewed by one of the local TV stations about the study. And I specifically said and made a big point of the fact that our study indicates that most women with benign breast biopsies, even among those with atypical hyperplasia, will not develop breast cancer. So the lead in the story on TV was alarming news tonight for women who've had a benign breast biopsy. So I'm telling you now, don't listen to what you hear on the news. Listen to the people who know what they're talking about. And your doctor knows a lot more than what you read on the internet and what you hear on the news.
Right. So clearly they are risk factors. Clearly they put women at higher risk than women who don't have atypias or other high risk lesions. And clearly we want women to understand that. And we want women to understand their options for reducing risk. But yes, we don't want people to feel like having one of these lesions is a ticking time bomb per se.